Hello, everybody. My name is Gabe Howard, and I live with bipolar disorder. And I am based here in Central Ohio. And I'm a patient advocate on the bipolar spectrum, and I'm super excited to be here. I'm 45 years old, so for a large part of my patient career, medical records were like these really private things that were off limits, and you had to fill out all these forms, and you could only transfer them from doctor to doctor. So, for the largest parts of my patient career, for lack of a better word, they were off limits to me. I didn't get access to any of them. And then one day, the patient portal arrived. Now, I recognize the patient portal doesn't have all of my patient records, but suddenly the sort of brick wall, the brick wall that said, records over here, patient over here, was torn down some. I had a lot more access to my patient records, what was going on, etc. Like I said, there was a patient portal that was right there. I know that now you can also fill out forms and get access to the actual, I want to say like hard copies, but there I I just can't get over that in my lifetime, in my patient career, in the last 20 years, how much more accessible patient records have become.
Welcome back, Health Impact audience. Today, we're going to talk with Dr. Chow a little bit about the information unblocking or blocking rules, depending on which side of the equation you sit on. So there has been for, I would say, several decades, the idea that electronic health records providers and others want to hoard all the data and they don't want to share any of this data with anybody. And the providers are out there saying that, if only the EHR companies would let us have access to the data, we would share it widely. Almost none of that is true. The reality is far, far more complicated with these information blocking or slash unblocking rules. And the reality sits in here where patients have new rights that they can demand now. The providers have new requirements. They have new things that they have to do in order to encourage and meet those new rights that patients have. But most importantly, we think that the solution providers and the innovators themselves are probably in a space now where they understand they can't hoard data and use that as a business model. So that's all good stuff, right? And so that's really where we wanted to have this conversation. Dr. Chow, tell us a little bit about yourself and what you do at Automation Anywhere.
Yeah, so I'm the global healthcare leader for Automation Anywhere. So I'm the strategist for Automation Anywhere. I've been looking at this issue for actually the last 2 years, and it's very exciting. We've been waiting for this moment. I would say we, the collective healthcare industry, have been waiting for this for the last 3 decades. And so it's an exciting day because you can see the progression step by step as the federal government, as Congress has listened to patients and is starting to make progress from point to point. And I'll talk a little bit about that later, to enable patients to expect to be able to get their medical record in electronic form completely and quickly and securely. And that's going to open the door to a lot of new things happening in the healthcare industry.
Perfect. So let's maybe start there. There's a lot of people wondering, what does the information unblocking or blocking rule, depending on how you're looking at it, really mean? And if you could imagine you're sitting at ONC and you're explaining this to everybody, tell us what is the rule and why it matters to me as a healthcare provider or patient.
Well, I think it helps to understand the background. And so it's going to be a long answer to a short question, but I apologize for the ahead of time. It's a story about the federal government unlocking data silos to address concerns about the cost, the quality, and value of medical care. And all those terms are really important. So it started with HIPAA essentially in 1996. HIPAA became synonymous with privacy and security protection. But actually the P in HIPAA stands for portability, or the ability for medical records to be portable. And the idea was a patient should be able to walk into a doctor, request the medical records, and have it be sent to them or to another doctor on a timely manner. And at the time, I think it was paper records. So to increase portability, HIPAA also encouraged folks to use electronic health records, or EHRs, and set up rules around protecting that data. But it was very slow progress. So Congress took the next step in 2009. They passed the HITECH Act, and it was a huge carrot and stick, basically, to encourage organizations to move to EHRs. And the results were very impressive. I think at the time it was 15% adoption. In a couple of years later, by today, it's about 95% adoption of EHRs. But it still wasn't enough. In 2017, just 5 years ago, the ONC published a design thinking based study on how the process of getting one's medical record actually works. And it was an eye-opening report. They interviewed patients, providers, administrators. What was disappointing was that even in the age of EHRs, the process is still fragmented and painful for both patient and provider. Lots of hurdles, lots of manual back and forths, a lot of paper forms even. It was the opposite of seamless. So what did Congress do? The next step was the 21st Century Cures Act, 2016, which took aim at all these barriers to medical record access. And the information blocking rule was part of that. It was delayed by COVID-19, but the deadline is now set on October 6th of this year. That's only 5 months, less than 5 months away. And so the information blocking rule says that patients must be able to electronically access all their EHI, electronic health information, that's a new term, structured or unstructured, securely and at no cost. This is revolutionary. So it is intended to enable an ecosystem of new innovations and new technologies that take advantage of this. And the definition of EHI, I will show on a slide. So the question is, what is electronic health information? It's not actually PHI. It's not protected health information, not the same thing. This is actually adapted from the ONC's own guide. So when you have let's say this is the protected health information, which is all electronic and paper PHI. The electronic EHI, the electronic PHI part of it, or ePHI, is, let's say, the light blue. And then this is a designated record set from HIPAA. So this is what HIPAA has specified. Now, the information blocking rule on October 6th says that you must make all this information available, everything in this designated record set that's electronic. Currently, the rule says you can have access to only US CDI or US core data for interoperability data set, which is a very limited data set. Before October 6th. October 6th, it expands to all this stuff. So I wanted to show this because it's important to understand for providers that it's actually a big ask. It's actually a big ask for them.
Yeah, and I think one of the key things about this slide, which represents it well, is that if you just think about your EHR, it's only a small portion of this, right? Then you add revenue cycle, it becomes a little bit bigger. Then you add labs, it becomes a little bit bigger. So you have to think about the entire set of data from hospitals and health systems as the entire block, not your EHR. Right.
Very, very true. So the ONC has specified a core technology for this, which is the HL7 FHIR Open API standard. It prohibits unnecessary delays. The penalty is up to $1 million. And the other part of that stick, as I mentioned, is that that CMS will publicly report on a wall of shame information blocking providers and providers that don't list an open, secure FHIR API endpoint. Now, there are some exceptions. ONC is saying you don't have to share mental health data, and you don't have to share pre-litigation notes, which is very obvious. So otherwise, the attorneys would have a field day. But now providers are facing some serious challenges. How do you respond to a patient or another provider for that patient? Request EHI in a timely manner. Are we looking again at hiring a lot more people in the midst of a staffing shortage, a staffing crisis? What additional resources or mechanisms are needed to gather and organize EHI data from multiple data sources like EHRs, PACS systems, lab information systems, legacy systems that may be in data warehouses before packaging in a compliant format for the requester. And then what if on October 6th, let's say we have 50 or 500 enlightened patients who want their data. And that is a lot of manual work if you don't have something in place. So since many of these steps are actually amenable to automation and even to intelligent automation, looking at paper records and things like that, these could be fully or partly automated so that the patient's request can be fulfilled without delay. And so you have to start today. To give a long answer to the short question, providers have actually been dealing with patient access requirements for many years. This is just the latest step.
Yeah. Yeah, so basically we can say it's real, right? The date's
Yeah.
here, and it got
Yeah.
delayed a little bit, obviously, because of
Mhm.
the pandemic,
Mhm.
but it's here. Might it get delayed again? Maybe, but only by months,
Mhm.
right? It wouldn't be
Mhm.
by years. So it's not
Right.
like you have a ton of time. So for sure, it's real. Number two,
Mhm.
we don't know how many patients are going to initiate that demand.
Right.
But I think your number of saying, if you have a patient population of 2 million, you
Yeah.
can bet
Yeah.
500 of them will ask. So for sure, some patients are going to ask. So some will ask. We don't know how many. But the biggest question, I guess we could end on is,
Mhm.
what is the mechanism for the fines? Like in the case
Mhm.
of HIPAA
Mhm. Mhm.
fines, that happens when they come in and do an audit.
Right. Right.
From a cybersecurity, personal, a privacy perspective. And
Mhm.
then there is a wall of shame. So all of that is real, by the way. There's a wall of shame today
Right.
for
Right.
security breaches. And so
Right.
that's
Right.
all believable. What I'm struggling with is what would they do? And just what is,
Right.
obviously you don't know the answer to this, but what is your guess about how they would
Yeah. So
police or audit
today,
this?
today is interesting. I mean, the enforcement agencies have been designated is the Office of the Inspector General, OIG, but there is a mechanism, a portal. Actually, I found a link to it where you can actually report violations today of information blocking. And I think we had a communication, and we actually put it in the description for the session. Over 300 have been reported since 2021. That's 300, potentially $300 million in fines. And that's a serious number. That'll get the attention of the CFO. Yeah.
Yeah, no, and in fact, so there's an issue tracking system that is already up. So what was interesting about this is they didn't. So the ONC did not go out to very large contractors to go build a system. They
Right.
just went to the cloud, picked up an issue tracking system. It's called
Right.
Jira. And they're just using that,
Exactly.
like
Yeah.
report your
Yeah.
issue like you would report a bug
Yeah.
to your IT system. They're saying use this system. So that's a great point to bring up, is that it's already in place. And I think this is where CEOs, CFOs, and others, where your question basically will boil down to is, if you don't do something, is it cheaper? Or
Right. Right.
if you're going to do it anyway,
Mhm.
why not do it for other initiatives as well?
Yes. Yes.
Do it for information blocking, because
Mhm.
one of the things that we know
Mhm.
that CMS in general, and especially the OIG, by the way, the OIG has more power
Mhm.
than other departments do
Right.
at
Right.
HHS. They're getting funded, right? So they've already
Mhm.
been funded, and I think they're going to
Exactly.
get more funding in the future. This is your basically the central question is, if I wait, does it
Mhm.
matter, right? And I
Right.
think that's
Right.
going to be the most telling thing is, if you waited and you did nothing, will you get more of a fine than if you started, did
Mm.
something, and
Mhm.
you look like you're not, basically being negligent about
Mhm.
it. And I'm not using negligent in a legal term, but
Right. Right. Right.
normal colloquial term. But if you were
Mhm.
negligent about it, are you going to get the same punishment? I think that's really the open
Right.
question.
Right. And I think weighing into that is actually the opportunity cost. So if you get started now, even with everything on your plate, you get started with a platform that you can use for many things. And you use that to solve this issue ahead of time, where you can think about how to do it properly, how to do it reproducibly and at scale. That way you can put that problem right to the side. You don't have to worry about meeting the compliance requirements. You can even check that process with the government, and people have done that to see, is this compliant? Once you get that sort of validation, then you end up with um, you're prepared for that, and you also have a new tool that you can use for many other things, and to meet the issues of scalability, accuracy, all these kind of things that people use automation for. So it's definitely a win-win. It doesn't have to be seen as as a as a burden, but if you don't take action, I understand many organizations don't have the resources, but if you don't take the action, I suspect that later on, dealing with this issue is going to take up more time, more resources away from anything else you're doing. So,
And Dr. Chow, the
yeah,
rest of the industry also has the same problem, right? So
right,
before
right,
even providers,
hmm,
the health insurance companies had to do their
right,
own version of this as well. What could
hmm,
reasonably enlighten leaders on both sides, like
hmm,
a health
hmm,
insurance company as well as a healthcare delivery network? How could they work together to maybe reduce the burden across
right,
multiple systems?
right. That's a really good question. I think when I was listening to Mickey Tripathi, the ONC head at HIMSS, he said basically this information blocking rule today is meant for patients and providers to providers, providers to providers. Provider to payer will be probably in a year. And then payer to payer, which is really interesting, will be in about 2 years. So he's sort of staged it like that, but I'm sure that's where everything is going. So what is the issue with payer to provider? The issue is that you have two different systems, a lot of manual back and forth, validation of ID numbers and back and forth with claims authorization, denials, all this kind of stuff. Currently, with the current scenario, I've seen actually a number of large organizations try to occupy the entire ecosystem so that the connection is a lot more seamless. They can use automation, send it to another automation, and you can fit together very well. And that's worked out very well. That also gives you a competitive edge. By the way, you can control costs and things like that. But in the future, just see that as a reality. That's actually going to happen. You have very liquid data flow between different systems. All of a sudden you can solve issues in seconds as opposed to taking days to solve it. And you can get accountability, you can track value, you can do a lot of things that were not possible before. So it's an exciting world. I think there are a lot of startups that are looking at it and drooling, to be honest. I certainly advise a few of those. And so I think it is a new world, but the opportunities are even larger. I think, you look at it from a traditional point of view, oh, this is going to be terrible. We get disclosing our secret data and whatnot. But, you just have to live with the fact that's where everything's going. Visibility, transparency, and in the new world, your competition, your model for competing is going to be very different. Yeah.
No, I love it. Great. Thanks for the introductory class to the information blocking rule. And what can patients expect to be able to demand now that they couldn't 5 years ago?
Well, there's a couple of things that have been part of what you call the information blocking rule. It's part of the 21st Century Cures Act. And so information blocking is defined as a practice that's likely to interfere with or prevent or materially discourage access, exchange, or use of electronic health information, which is all the information related to the care decisions that were made for that patient, including billing data. So it applies to any request for EHI from either a patient or their authorized representative, which could be another healthcare system. And so the information blocking rule has specified that healthcare providers must comply, developers of certified health IT must comply, health information networks must comply, health information exchanges must comply. The rule says you cannot take too much time. It has to be a reasonable amount of time. And if you're using actually a certified EHR, which most providers are using today, that is actually possible. You can actually meet that requirement. Now, the stick that the government has put in place is huge. For every violation, if you don't comply in a reasonable time, the penalty can be up to $1 million per violation. So if you, on October 6th, if a provider gets 500 requests, it adds up pretty quickly. And so it's an exciting day for patients, and it opens the door, as you said, to innovation like crazy. A lot of people were waiting for this to be able to do big data and analytics, to do AI, to do all kinds of things.
Right.
Yeah.
So could one imagine then, Dr. Chow, that if you're already using a certified EHR, you're pretty much set. You can do whatever you need to do and handle all the things that patients are asking for? Or
Right.
are there things that EHRs don't do, and they really need other solutions to help bridge those gaps?
You need a little bit more. What the ONC did when they did the certification of EHRs with the High-Tech Act, 2009, is that they certified that the EHR must be able to present information electronically to external inquirers, external people who need that. And so by token of that, they should be able to do that. However, there was no mechanism to do that. That is, because the EHI, the electronic health information defined by the ONC, is actually not just PHI. It's actually what they call a designated record set, which is part of the original HIPAA rule in 1996. And it goes beyond the EHR. It includes billing information, may include lab information, test information, all kinds of things that impinge on patient care. So it is actually a challenge to collect all that information from legacy systems, disparate systems that may not be in existence anymore, things like that. And that process is what is required. So automation, of course, can help a lot with that in terms of extracting data, correlating it, converting to the right format. You have to provide that format in what the ONC is recommending, the HL7 FHIR format, FHIR. And that's going to be the standard uniform glue between all these different parties in the healthcare system.
And what do you guys jump? So when someone comes to you and says, look, our EHR by itself is not cutting it, our lab system by itself is not cutting it, we've got to aggregate too much data. What exactly does Automation Anywhere do when you come in and you try to pull these things together?
Right. So Automation Anywhere is a platform. So it allows you to do a lot of things. You can actually look for data that's required. It's interesting, the ONC, when HIPAA specified the designated record set, there is no specific list of things that you have to get, which is really interesting. So the ONC has said that since HIPAA, you should understand, quote, understand what that information set is, but of course it changes over time. So for every organization, it's actually a different challenge. So when they go in and you look at all your systems, your legacy systems, all the things you've put in place, including the EHR, maybe even other kinds of data sets from the previous EHRs and things like that, that is a mess. So you have to go in and you have to figure out, okay, we have to present this to the patient in 3 days. What do we get? What satisfies that rule, that compliance, and won't get us dinged? And that's actually requires some human judgment, but once you make that initial judgment, that process could be automated for everybody. It's the same, for your organization, that's the definition of your designated records. That's your deliverable that you're obligated to do.
And do you get the sense that as you walk into the companies, that's one of the hospitals and health systems, is that one of the first things you're helping them with, is describe and define their designated record set, or do they often know that already before you come in?
They are actually struggling. It's actually very early. The deadline is October 6th. And I keep telling people it's only 5 months. That's not a long time for a software project or any kind of project. So when you walk in, they're still trying to figure out how you deliver it. Now, some of the EHR vendors, for the EHR part of it, they're starting to develop mechanisms to help their clients be compliant. But there's still the idea of getting that data, packaging it in a standard format, so the patient can take away what they expect to take away, and including all the other sources of data. So they're just starting to do that. We've talked to a couple of folks. I'm a little bit surprised, by the fact that people are just starting to talk about it. Maybe not that surprised, but I think it's going to come quickly. And automation is going to be one of the few ways, as we get closer to that date, it's going to be one of the very few ways you can actually do it and satisfy that requirement.
So as you look at helping companies, when you come in and they are worried about compliance, do you try to dissuade them and say, look, don't worry, yes, it's required for compliance, but if you do it right, here are the 20 other things you can do now that you're doing this properly.
Right.
So I get the sense that if you just go to a senior executive or to the board and say, look, these are compliance rules, nobody's that interested in the project, nobody's going to push it that hard. But I think if we say, look, when you do this, you're going to meet the rules, and now your brand is improved. You can retain patients better. You can acquire new patients better. What could you do if you were doing this properly? That would be more opportunities for you to get either better revenue, improving your network access to different physicians, etc. How could you go beyond compliance, if at all? I
think it depends on the maturity and the leadership of the organization. We've seen a wide range from folks that are seeing automation as an infrastructure platform. That is, it's part of their end-to-end strategic roadmap. And that's a very different perspective. That's a C-level perspective versus let's solve this pain point in revenue cycle. So we're meeting a lot of different kinds of audiences, but I think COVID has really pushed the strategic piece of it. We're starting to see a lot of meetings with C-level because they're worried. COVID is still going on, and we don't know what the scalability requirements will be, what the demand will be, what the supply, staffing shortages is going through the roof. So there's a lot of issues where you want to be able to control what you can control, which is all the mechanical pieces of it that require human labor. So it's not been a hard argument, but the challenge sometimes of organizations, they have a lot on their plate, obviously, and this is just one of those. But it's sort of, sometimes it's managing crisis by crisis, and right now the number one crisis is probably staffing shortages, and we have a role to play there as well, but it's a different role than this information blocking.
Yeah, although this is, I think you hit
Mhm.
on something that's very, very important, and that is if we can talk to C-suite
Mhm.
members and they can say, look, I've got 19 priorities, which means you have none, right? If you have 19
Right.
priorities, it means you have no priorities. So, but if you had two priorities
Yeah.
and
Yeah.
the other 17 of them could be handled with the first two priorities, I get the sense that if you can handle the idea of data aggregation, data automation, data
Mhm.
analytics, et cetera,
Mhm.
you're setting yourself up for a lot more
Yeah.
initiative to
Yeah.
be
Yeah.
properly concluded
Right.
than just treating everything as separate. So when I talk
Right.
to CEOs,
Mhm.
especially CIOs, they
Mm.
would love.
Mm.
I mean, they're abstract thinkers. You go in and you
Right.
say, well, how can I do one thing and solve 9 problems?
Right.
But
Right.
we often, from the solution side of the equation, do not come in like that. We're like, okay, let me help you with this because we want to close a deal. We need
Right.
to,
Right.
generate revenue for the quarter. So, I mean, all realistic, very, very realistic kinds
Uh-huh.
of challenges.
Mhm.
But I think you guys sit at Automation Anywhere in a nice middle area where you
Mhm.
say, look,
Mhm.
yeah, you got a lot of
Yeah.
priorities, but almost half of them or 3/4 of them are handled by automation. Is that a reasonable take on what you're doing?
Yeah. Yeah. Actually, that's a good point. We're finding that we mostly speak with both with the CIO and the CFO. Of course, when we speak to the CFO, we know what the CFO is interested in,
Mhm.
which is a value engineering solution. That is, they want to see, short term, middle term, long term. What is the return? What is the return in terms of hours saved, in terms of maybe accuracy, productivity, those kind of things. When you talk to the CIO, you're right. It's a little bit different conversation. It can be broader, and especially if you talk to somebody like the chief medical officer, you're really getting to clinical kinds of things. Having that platform in place, we'll always say it'll take you at least 6 months, a year to really get the in-house expertise to really ramp up. You need probably a center of excellence. You need probably at least 1 or 2 IT dedicated folks to understand this. Uh, Even though our platform is very friendly for business units, that they can start the design of software automations, but ultimately you need to put it into production, and you need an IT capability for that, and governance, and so on and so forth. So that roadmap is pretty clear. We have a very good idea of what it takes to succeed based on our customers. And so when we talk at that level, then it's much easier to see that this is actually a strategic tool. It can solve many problems in many business functions, and as you know, it's not a function-specific tool. The little secret is that it actually automates everything in every department, as long as you can think of the application. And we even have a tool for that. We can discover what the processes are. So I think it takes a little bit of time to get that to the highest priority, but we're finding it more openness to that today. Yeah.
Yeah, and the other openness can come in as when you look at Gartner and Forrester, they have the
Hmm.
concept of the digital twin.
Hmm.
We
Hmm.
in the healthcare industry don't feel like you could create a twin of a nurse. You could not create the twin of a
No.
very well experienced coding professional, for example.
Hmm.
Certainly, you can't create a twin of a doctor. You'll hear that very often.
Right.
As a
Right.
doctor yourself, talk about what explain a little bit on what is a digital twin,
Hmm.
and then is it really applicable in healthcare to create these digital twins, and what would that look like?
Well, there's a couple of issues related to that. A digital twin is essentially a model. It's a computer simulation of something in real life that you can experiment with. You can actually do different experiments without having the expense and the risk of doing it in real reality. The problem with digital twin is that we're finding in healthcare that many of the things that affect healthcare status are beyond medicine. And so we're talking about what we call the structural determinants of health, the social determinants of health, your education, your neighborhood, your access to the clinic, your access to good food, things like that, your income level, education, all this kind of things. So when you talk about that kind of data, it's very messy. And so what you're having is big data issue that could be amenable to AI analysis, but collecting that data and understanding how to weight each factor is a huge challenge. So I think the digital twin model will work probably eventually. Maybe we'll get something useful, but right now you're talking about a lot of information that is not easily modelable, not easily simulatable. And so it's a challenge. And the other thing is, medicine works on evidence, evidence basis. So if you're creating a digital twin and you're trying to see correlations in data, that is not equal to causality. And so if you don't have causality, how do you defend your actions, your decisions based on that model? And that's been a big challenge. That'll require a new kind of statistical analysis called causal inference. And that is starting to take hold. But it's a whole new world. When you look at real world data, big data in healthcare, you have to use different techniques than clinical trials. It's just not possible.
Got it. Yeah. And so in the last couple of minutes that we have here, let's talk about, we're always taught not to boil the ocean. It's a bad strategy. So if you're not boiling the ocean and you are starting with information blocking / unblocking as your strategic initiatives to bring in a tool for automation, what would you start with, right? What are the quote low-hanging fruit? It's a bad way to say that, but where do you start so that you could treat this as a long-term initiative for a variety of different purposes, but that you can get it started pretty quickly?
Yeah, so that's a really good question. Many times we're called in to boil the ocean. We just don't have enough fuel to boil the ocean. So what we usually do is ask about revenue cycle. That's probably 80% of our engagements in the beginning. The reason it is for two reasons. One is that the processes are very manual. They're very well understood. They don't change very much. And it's an opportunity, number one, for the new organization to automation to learn the platform. And that's really important. They need to know what it can do, what it cannot do, which partner to work with, and all these kind of things that they need to decide. That's number one. The second thing is you need a fast, very quick return on investment usually to show the validity of automation, to the benefit of automation. So it turns out that revenue cycle does that. It's a lot of processes of revenue cycle that throw off cash, that save hours upon hours of labor. And we're talking about a labor shortage. It's going to get everybody's attention. So being able to, in fact, I just had a conversation yesterday with a big organization on the East Coast that is their main problem. They're already overstretched. They can't hire enough people, not enough people available. How do they make the remaining people do more important work and not do this paperwork that they've been doing? So I think revenue cycle is usually where it starts, but it sort of depends on the organization. As we get closer to October 6th, it'll be the information blocking rule for sure. But revenue cycle to start, we're seeing a lot of interest in HR, finance, credentialing, even clinical use cases are starting to come to the fore. I had a conversation today about automating the ER for ER physicians to have a dashboard for all kinds of data that could be manipulated, and so the physician could actually assign priorities. And this is something that is I think this is probably the most exciting part. We want to improve care for patients, and there's a lot of opportunity as long as people are willing to look at it.
No, that's perfect. And just from a summary perspective, by the way, more than half of our hospital and health system CEOs and CXOs are not going to treat information blocking as a real threat until the first fines get levied.
That's right.
Until the first lawsuit comes in, which is not necessarily. I don't blame them. I would wait to say, yeah, it's nice to say it's going to be $1 million fine, but where is that going to come? That's the one area. The second area is that we're going to have to find, there's just way too many priorities. So we're going to have to find ways of saying that you have to choose one strategy that kills, multiple birds with this one strategic stone that we're talking about. And I think this is one of those few areas where automation can and should do that. One of the smartest CIOs that I know in the industry, he taught me this in our earlier days when I was working with them, is he said, look, if you can solve your revenue cycle problems, you'll find money to go pay for everything else.
Exactly.
So maybe the smartest thing to do is just work on the revenue cycle problem, tie it to information blocking, because when you do that, you can get it there. And then say, look, this money is going to generate what I need to go do all the other stuff, including making sure that we don't get information blocking stuck. So does that make sense?
Makes a lot of sense. I think as far as the information blocking rule is concerned, it does bring some fundamental changes, as you mentioned. It's not just revenue cycle, it's the approach to healthcare itself. So before information blocking rule, the competitive model for healthcare, it was based on leveraging hidden data, And now the model will switch to capitalizing on new insights from a larger universe of data. as well as partnerships with all these new innovation companies that are coming up to take advantage of it. So I think it is actually a new world. Is for patients, it is a whole new game.
Yeah, and so let's talk about that one last piece with
Hmm.
respect to patients, because we said that they will have new demands. They will be able to
Right.
make new demands.
Hmm.
The vast majority of patients will not know that they have these
Hmm.
capabilities to make the new demand, so they're not going to
Right.
make it on October 6th.
Right.
It'll be soon after. But is what you're talking about with respect to information
Hmm.
blocking rule going to give new things that so say that there are insiders within hospitals and health systems that they can see the writing on the wall, they're going to do the right
Hmm.
thing,
Hmm. Hmm.
but now they can use information unblocking as a vehicle to do
Hmm.
other things that they've wanted to do. Can you think about
Exactly.
that maybe? How would we advise CEOs to
Yeah.
say, look, if you're super smart, do this
Right.
using the information unblocking rule as a vehicle?
Right. So I think that, for the visionary leaders in healthcare, the opportunity is to expand your definition of healthcare. And so what you can do is, what the ONC has thought about, what Congress has thought about for many years is that, yes, a patient comes to you and the patient is using some independent app, and the app wants to get information for whatever reason, second opinion or whatever it is. And so that app will now have the right to get that information electronically fast. What you could do to preempt that is you could start to develop both sensing and activating apps outside your ecosystem that help the patient to do things that they would need to do, such as bring in information about medical record and tie it into the local availability of groceries that are needed, or access to physicians. There's a lot of things that patients need, especially the caregivers of patients, that they can't do today because they don't have access to the information. If you preempt that, your loyalty level is going to go through the roof. Patients are going to be so happy. And of course, you do it with a useful UI, with as few barriers as possible. And that's a big change for healthcare. But I think, the forward-thinking organization is going to think, we don't want to be the healthcare delivery, person. We want to be the friend that's going to be your friend through life, advising you in this much larger ecosystem of related to your health. And I think that's where the opportunity lies.
Yeah, and if you think about it, and looking at the visionaries, the one who can
Hmm.
see, a couple of years into
Hmm.
the future, what a lot of them don't recognize is that
Hmm.
when information unblocking gets cleared up for patients,
Hmm.
you can actually ask patients to collect data that they would have
Right.
not otherwise collected on
Right.
your behalf, right?
Right.
Just as an example, before we used to do our own check-ins at the
Hmm. Hmm.
airport counters,
Yeah.
staff had to do all that work.
Right.
So if you could start to think and say, all right, using tools like Automation Anywhere or
Hmm.
additional capabilities through
Yeah.
APIs that are coming in,
Hmm.
how could I put self-service onto
Hmm.
my patients that they would
Right.
be more than thrilled to do on
Right.
their own? Like
Right.
we actually like the idea that we can get our own check-in done. We don't
Yeah.
want to go
Yeah.
stand in line anywhere,
Yeah.
etc. And I
Yeah.
think that's really something that it's a hard thing to
Hmm.
answer.
Hmm.
But if you don't have if you haven't established the data aggregation, the
Hmm.
capabilities to connect all these systems, you can't think
Hmm.
of anything else, right? And
Right.
that's really
Right.
why you got to get this established,
Mhm.
because there is no
Yeah.
scenario. I don't think there's a scenario where any EHR vendor or groups of EHR vendors are going to
Hmm.
solve this problem of
Right.
connecting all the myriad, hundreds of systems in the back end at the hospital. So
Hmm.
just in the last couple of seconds that we have, are there things like that that you can think of and say, you know what,
Hmm.
if our patients had
Hmm.
API
Hmm.
connections to other vendors,
Hmm.
meaning let's say another hospital, that we could save time and effort by
Hmm.
giving them access to our data so they can connect to the other system
Hmm.
and
Hmm.
push the data into ours, right? That's a way of saving time and effort.
Yeah. Actually, that's actually probably one of the first issues that HIPAA addressed, 25 years ago, which is how does a patient coordinate care between different specialists? That's been a huge issue forever. And so putting the patient in control is probably the key piece of it, or the patient's caregiver.
Right.
Somebody who has the vested interest to look over the entire landscape and say, you know what, I'm going to be in this city for this specialist. Can I group all those appointments together? I need to get these tests done. Can we aggregate those appointments? I can't afford this one. We have to go to someplace else. All those kinds of things are things that are not easy to coordinate. You have different fragmented providers. So you're right. I think that there's a lot of things, and way beyond that, there's a lot of things that patients could be doing But I think for organizations providing this access, there's really an upside. And as I mentioned, the upside is being able to look into the patient's world much better. So
Mhm.
if you create that tool, then you actually know what's happening with the patient. You can deliver personalized care. I mean, personalized not just from a genetic point of view, but from a social economic point of view. A kind of care that's likely to result in near 100% compliance, agreement, satisfaction, all those factors that either get you a plus sign or a negative sign on Yelp. So I think there's a lot of potential. And in fact, the two side issues, one is that you need data to do AI. And so to have valuable AI, you need to have valuable, and you have to have a lot of data. And the second thing is that the government is actually pushing this. They want real world evidence to be part of the picture. It's not clinical trial evidence, it's real world, in the real world, collected from real life. And I think ultimately that's where healthcare needs to go.
No, I love it. No, that's perfect. So thank you so much for this
Sure.
nice interactive discussion about what the information unblocking rule is focused on, and that tools like Automation Anywhere can certainly come in and handle those areas. So really appreciate you shining some light there. And for our audience members, please reach out to Dr. Chow, have those conversations, and really think about one thing, and that is there are reasons to do this because patients are going to find more value. But there are just as many reasons. If you're a selfish organization, lots of us are, but if you're a selfish institution or a selfish organization saying, look, what's in it for me? Dude, if you can pull a lot of this technology in, it turns out that patients will do more work for you.
Yeah.
That will reduce the workload on your own staff. And I think that's a win-win for everybody.
It is. It really is. And I think that's what the ONC and what Congress were hoping and aiming for. So I think it is a new game for patients and providers.
Fantastic. All right. Thank you very much.
Thank you.
Hi, I'm Janae Sharp, and I'm sitting down with Dr. Matt Sullivan to talk about information blocking and the Cures Act. And I would love it if you could introduce yourself, and I'm looking forward to this conversation.
Yeah, well, thank you very much for having me. I'm Matt Sullivan. I'm the CMIO at Atrium Health. I'm an emergency physician originally in my training, and also board certified in informatics, and have been working in this space for a while. So glad to talk to you.
Thank you. I'm looking forward to this too. I love the Cures Act, and in theory, the idea that patients can have their data. Everyone can have the data that they need and their health data. I'd love to hear from you, like how are payers, how are providers, how are health systems, like how are they responding to the Cures Act?
Well, I think there's a couple of answers embedded in that question. So the providers are struggling a little bit. This was an act that was given to us in the way that sometimes the federal government gives us things, and in so doing, the providers didn't really have an option to react in the way that I don't think they were fully informed, frankly, and that's part of the problem. And so I think that the intent of the law is good. The idea that patients have their data is a good thing. The idea of how and when is the hard part for us to figure out. And so when we try to understand exactly when is the right time for someone to get a diagnosis of cancer, that's a tough one. Who's supposed to deliver that information? I think many of our providers are really concerned that tech-savvy patients have access to the portal, they have access to their medical record. And it's not that we're saying that they shouldn't, it's that when those test results, whether it's a CT scan or whether it's a series of laboratory tests that come back, if they don't have the medical acumen to digest the answer, understand what it means, or in some cases, even put the pieces of care together with where they are in their stage of care, then it complicates the delivery of care, and it affects the way that the patient perceives their illness, and perhaps even the patient-physician relationship. And that's troubling because generally as physicians, we like to maintain that physician-patient relationship, and we'd like it to be good. We think it's part of the profession. And so it's really upsetting. And I'll use the emergency setting where I've practiced for many years as an example. The idea that you would think that someone has maybe diverticulitis and you're worried about an abscess, you get a CT scan, and before you have a chance to see the results yourself, maybe you're taking care of another patient or two, and the patient has, full-blown metastatic cancer in their abdomen that they didn't know about, and the patient sees that on their telephone, on their app, before you have the opportunity to go in and set up the care. And those of us that are really trying to practice really well would see those results, make a phone call, try to figure out who their primary care physician was, maybe even call the oncology to arrange follow-up, and really walk into the room fully prepared to deliver bad news with the idea that we have our arms around the patient to say, hey, look, I'm really sorry, you don't have diverticulitis, there's no abscess, but you have something else, and it looks like you have pretty bad cancer. I've talked already with our oncology team. They want to see you tomorrow. And that's the kind of healing that we'd like to do. Unfortunately, the Cures Act requires that we release that data immediately. And so there's really no good way to know who's going to have a bad result and who doesn't. Now, I think the solution is simple. The solution is that you have a conversation with the patient and you say, hey, I'm going to order a test here and I don't know what's going on. I think it's these things, but there may be something really bad that's happening here. Would you rather that I tell you the results, or would you rather get those on your portal? And if the patient says, I absolutely want those on my portal as fast as possible, fine. If the patient says, I would love it if you would tell me the results and then we can talk about them, then I believe that there's no legal problem with holding those results until you've had time to make that conversation. We've explored that. I think that's a viable option. I think that's the way that patients really have control of their medical record. And I think that's actually the spirit of the law, is that we want the patient to have control. So that's a long-winded answer.
Yeah, that's a good answer. I've thought about that too, like with having babies. Like I got tests and sometimes I was like, what is this even? Like, why am I even doing this? So I like the idea of patients being able to control it and being able to have support from their doctors, and that perspective that it's about like what the best care is. And like that seems like one of the drawbacks. What are the pros that you've seen like across the industry, whether that be like technology or I think of a story like my grandma. She was like in rural Washington, right? And she was like, I have to go get some nuclear tests. Like she would always talk about the tests she had to go get and all this stuff. And just like, she was like, they just try to get you to get all the tests, So when I think of information blocking, sometimes I think about like my old grandma, like going around being like, I have to get the same test again. Really good voice impression. That's my second talent. So I wonder, like, have you seen anything that's kind of a development or ways that's helped you deliver better care or decrease costs?
Well, I don't know that we could say that the idea of releasing information quickly to a patient is going to lower the cost. I think the idea that we...
Oh, that's good. Good point.
Right. But I think that the idea that we would not withhold information, releasing it to another organization may. And again, going back to where I've worked for a while in the emergency space, if you've already had a CT scan done at a facility that's not yours, and it was done yesterday, there's probably not a lot of good reason to repeat that. And it would really actually accelerate the care. And you need to know, hey, I've already got, yesterday they did all these tests. We don't really need to repeat all of them. We might need to repeat one or two, or we might need to do something differently. But certainly withholding information is not the right answer. And that's true interoperability. And that's been sort of the holy grail for a while, is trying to get our systems across the US to talk to each other. But I think that your point about your grandmother may or may not know how to interpret those results when she goes to get that nuclear test, that is. But maybe
definitely did not.
Well, maybe she's really savvy. Maybe your grandmother is been dealing with diabetes or hypercholesterolemia or something for a long time, and she knows all the details, and so she really wants to know, my cholesterol doing the same or better? And maybe the doctor has already said to your grandmother, look, I'm going to draw your cholesterol again. And it's always been 250. If we can get it down below 220, we're doing a great thing here. If it's higher, I'm going to need to add a different medicine, but we'll figure that out when the lab tests come back. And then your grandmother looks at her phone on her brand new iPhone and she swipes over and says, ah, it's 210. Sweet. I don't need to go on another medicine. Or she says, oh, it's 260. Ah, shoot, he's going to call me back and I'm going to have to add on another medicine. Bummer. But that's the kind of conversation that the physicians already had with the patient to lay out the groundwork. And in some cases, there are patients that are really both tech savvy and medically savvy around their own conditions, where they will want to get those information, that kernel of information really quickly to them, so that they're happy and that they understand what the next step is. And even if it's bad news, the next step may be fine. They understand it because they've been prepared for it. And I think that was also part and parcel of what we're trying to get at here with the 21st Century Cares Act, was letting patients engage with their health information and engage with their physician, to have that conversation so that everybody's a little bit smarter about it. And I think that's a pretty good thing. Were we all to have endless amounts of time, it would be great with patients and talk endlessly about this stuff and get them fully prepared. And then it would be easier actually to take care of them.
Yeah. I think that's a good point you just made too. If we had enough time, like time is really the most valuable commodity, right? So have you seen tools that, or whether that be technology or the way you work together, that have helped save time with this?
Well, specific to the Cures Act or releasing information, I think part of the deal is you've got to take that information, deliver it to the physician in a quick, easy manner, and then have the physician recognize that it's there, or the physician's team in the office recognize that it's there, and then act on it. And so any of the tools that we have seen that have helped with message center inbox kind of management and hierarchy, to say, okay, look, here are the new things that you need to look at pretty quickly. These are flagged as abnormal, probably ought to deal with those first, allows us to get at the information more quickly and then deliver that information to the patient in a timely manner. And I think that supports the intent of the law. It's also good care. Patients love that. It increases patient satisfaction. So those technology tools, I think we're going to see more and more of their use. Certainly in
I wish they had that for real life.
Well, yeah.
I could use that in my real life. Yeah.
Well, I think that's, time management and lab management, result management, all of those things. And as we think about what might happen in the future, as far as developments of innovation, how do we take really bad news and quickly deliver it to the right person at the right time, so that everybody gets information as quickly as possible, but gets it in a way that is really kind and really consistent with how I think most of us want to practice medicine.
Yeah, I want to thank you for that story and for sharing the perspective of the challenges with patient data. What do you want to see in the future? Like, what's
I actually think
investing in data?
Yeah, I think as far as the 21st Century Cures Act goes, I've seen a number of the FAQ responses from the ONC, and we're on the first stages of where some degree of authority will come in and
right.
Smack down somebody, and I'd like to at least see a little bit of judgment there, and I'd like to actually start to think about the national conversation around how could we take the law and make it better in some way, to deliver a smoother transition. Obviously, I don't want to see us say, oh yeah, everything has to be held. I think that's inappropriate. I don't think that anybody would think that. I think most of us generally understand that for very complicated processes, very complicated lab tests that need interpretation just from the test, but not only that, but the interpretation of what that test means in relation to the patient. I think those things probably need a fine-tooth comb, and there needs to be some changes in the law to accommodate that and not hold hospital systems and providers in some sort of breaking the law kind of a mode. I think that we can do that with a normal, appropriate national discussion. And I think that probably will happen here. I've seen a number of states do this. We've watched a couple of states create their own versioning of this. I don't know that I have a good idea of who's doing the best, but I think if we took that kind of conversation and took it to the national level, we'd be one step ahead.
Yeah, I think that's a good idea. So if anyone from the national, level wants to connect with you, we'll send them your way.
Gladly.
And I want to thank you for sharing that and for coming.
Wonderful.
So
Look forward to it.